a show designed to use the power of Google Plus to bring interesting and innovative therapists and those interested in psychotherapy or counseling together to share their work, their thoughts, their ideas with each other. Hi, I'm Neil Brown, a therapist and management consultant with over 30 years of experience. And now, after enjoying a successful career, my desire is to share the wealth of knowledge I've been given with others and to help other innovative professionals share their knowledge and gifts as well. That way, we'll form a community and learn, grow, and engage and share together. Our program is being produced today by Robin Holland, who will bring us your questions and comments, so don't be shy, bring them on. Thank you, Robin. I'm thrilled today to present to you a licensed clinical social worker, Pat Harvey. Pat is an author, psychotherapist, parent coach, and trainer of mental health professionals who specializes in working with parents and family members of children, teens, and young adults with intense emotions and difficult behaviors. Pat has written several books, including Parenting a Child with Intense Emotions, which is being read all around the world. It has been translated into several languages, including Mandarin, so you know everyone's struggling with these issues, and offers a path forward for parents of these often challenging young people. Pat is former director of mental health programs for teens and young adults that were among the first to use a DBT therapy model, and we'll learn more about what that is. One of her programs received a gold award from the American Psychological Association. Hello and welcome to you, Pat.
Hi, glad to be here. Thanks for having me.
All right. I think we're coast to coast. Where are you broadcasting from?
I'm in Rockville, Maryland, where it is 3 o'clock in the afternoon.
Where it's 3 o'clock in Rockville. And how's it going in Rockville? What's it like out there? Where I'm on coastal California.
It is actually really hot after a sort of very weird spring. But today it's hot and muggy, and I'm really glad to be inside.
Okay. Well, good. You have an AC? What's that?
The sun is out.
There you are. And do you have AC in there so you're cooling off?
Say it again?
You have your AC on inside?
Oh, absolutely.
Okay.
Absolutely.
So you have created this very important specialty in working with family members of young people with intense emotions and challenging behaviors. Where did that come from? How did you develop that particular area of interest?
When I was running my programs in Massachusetts, the kids in the programs who were adolescents and young adults all had a DBT therapist, they had family therapy, and they had a lot of immersion into dialectical behavior therapy from their counselors. And what I wanted to do was I wanted to do some clinical work myself because I was the director of the program, and I've always had an interest in working with parents. And so I decided to start working with the parents who I would meet once a month, because they came from different areas of Massachusetts, and I started teaching them the skills. The thing is that while I was teaching them the skills, they were actually telling me what their lives were like, and it was a lot of new information to me because I had been so focused on the kids themselves and what their lives were like and what their parents had to do to help them that I hadn't given a whole lot of thought. And so, you know, sometimes I would get a referral with a kid that would say, oh, watch out for these parents, they're really sort of difficult. And when I got to know the parents, what I got to understand was how many years they had been living with kids who were suicidal, how many different programs they had been through, how many times they had to tell their story, how much judgment they faced, how much blame they faced from mental health professionals all over the place. And I became really interested in just trying to provide the support and the validation for them that I don't think that they were getting very much else. And so when I moved down to Maryland, I found a group of parents who said, look, our kids are in Utah, and our kids, some of them are not in programs, but we want to learn the DBT skills. And that's what I've been doing ever since. I think it's a population whose needs are not met very often, and I want to make sure that I meet them. And that's what I've been doing for 10 years.
Well, that's powerful and wonderful, and I think it certainly fits with my experience, and certainly I think a lot of parents experience that it's all the parents' fault, and they carry the burden of it, and if we were only perfect parents, we would have perfect kids. I think that didn't start with Freud, and everything's about the mothers, everything's the mother's fault. Now it moved on to hero dad and blaming mother. So there's lots of challenges for parents who have kids with special needs. Indeed.
No, I did a parent group way back in my first career, which was in the late 1970s actually, and it wasn't. I didn't do it for very long, but the one significant thing I remember was a parent saying to me, "I wish my kids had developmental disabilities rather than mental illness, because nobody blames us for a kid with developmental disabilities. And with mental illness, everybody's looking at us and looking at our kid and saying, what are you guys doing wrong?" And so I always remember the power of that statement and the power of what parents experience when their kid has intense emotions, mental illness.
Well, I very much appreciate the compassionate view that you're bringing to parents, and they need it desperately. But before we talk more about that, please help us learn about what is DBT. What is DBT?
Okay, so dialectical behavior therapy is a treatment formula. It's a treatment that was developed by Marshall Linehan over 20 years ago. It's an evidence-based treatment, which means it's been well researched. It was originally designed for individuals that have borderline personality disorder. It's since been researched with lots of other populations. It's been researched with adolescents. And what it does is it takes a cognitive behavioral framework that focuses on changing behaviors and changing thoughts that lead to emotions that lead to behaviors. And it basically says, it takes that formula and says that before we can help people change, we have to really accept them, that they're doing the best they can, and that they have brains that function differently. And that it's only when somebody feels accepted and feels heard and feels like people get them that they are also able to then hear what we say in terms of advising them about changing. That when you go in too quickly to change people, all of us, none of us, are going to say, oh, sure, change me. What we're going to say is, leave me alone, you don't get it, you don't understand. If somebody comes to me and says, you know, I realize that you're struggling, and I understand that you're in a significant amount of pain, then, at that point, I'm going to listen to what they have to say. So Marshall Linehan added acceptance to the idea of change in a dialectic. So the dialectic is you're doing the best you can, given the way your brain works, given the complexities of your life, and if you want to have the life that you want to have, you're going to have to make some changes. And then around that, there's a skills base about maybe people don't actually have the skills they need to manage their emotions. What we look at is that behaviors, the problematic behaviors, self-harm, suicidality, substance abuse, aggression, are really ways that kids have learned to manage the pain that they're feeling. And so it's all about behavior. It's not about character flaws. It's not about hopelessness. It's about you can learn different behaviors to change and manage your pain. So when I explain that to parents, they get hopeful. And the kids that my colleagues work with get hopeful. It's like, oh, I can change behaviors. Just don't make it about me. Don't make it like I'm so flawed that I can't ever get better. And borderline personality disorder is very stigmatizing as a diagnosis because that's all those kids who were like Girl Interrupted, like Glenn Close in Fatal Attraction, that people felt like they would be that way forever, and parents thought their kids would be like that forever. And Marshall Linehan said, no, people can learn new behaviors, they can have their lives back. And so it's actually a really hopeful message.
Doesn't it go back to, in Western psychotherapy, doesn't it go back to unconditional positive regard as a starting point? More toward more Eastern philosophy and more of a Buddhist philosophy of acceptance and compassion.
Yeah, I think it is. I mean, I think it's about acceptance and compassion, and it's also about change. And that's the thing that actually gets parents to buy in a little bit. They're willing to do the acceptance. I'm also willing to say to them, okay, and this is how we're the clinicians and how you are going to also help with change. So yes, I think it is. I mean, Marshall Linehan is very steeped in Buddhist tradition. Very much had to experience her own self-acceptance in order to get on with her life and get through her life difficulties. So I think that that's where it is really steeped.
Okay. So what you're saying is, in order to move forward, we have to start with acceptance of an essential goodness in the person, accept essential okayness. You can't start with you're a flawed person. You have to accept that you're an okay person. The behaviors are not working.
I think whether the person is okay is sort of a judgment, and we don't judge. So what we start with is the fact that the person's doing the best they can.
Doing the best they can.
Given their life complexities, given how difficult their life is, that they're doing the best they can in this moment at this time. And then, if they want to have a different kind of life, then they have to make changes.
Okay.
That's how I see it. I don't see it whether a person's okay or not, actually.
Okay. Got it. So, no, that's fine. That's helpful. And so it applies, I suppose, at two levels. One is the message that you're giving parents that they're doing the best they can. And then going to the next level where the parents give their young person the message, I know you're doing the best you can, and I accept that about you.
I think the amazing thing about DBT is that it's really about all of us. Okay? So all of us, even us as clinicians, are doing the best we can, and we're also going to work always to become more effective and better at what we are. Same for parents, same for kids. DBT is not anything I say to the parents that I work with. I say to myself, and I say to anybody I know. I don't see it as a me, the clinician, you, the client. I see it as this is the way we have to see things. Dialectical behavior therapy is very much a part of me, and whatever I give to parents comes really from inside me, not from what I've learned, but what I've also incorporated into my life.
So even as you talk about this, I find my shoulders coming down a little bit. I find myself relaxing. It's like, okay, we're all just here doing the best we can. This isn't about this new idea that I have to learn to go fix somebody. We're just all going to get present. We're all going to start with a place of acceptance. We're all doing the best we can. And maybe there's something we can learn and grow from, but we're going to start with a position of acceptance and okay.
I think one of the important messages for parents, parents carry a phenomenal amount of guilt. There's not a parent listening that doesn't know that or feel that, and I think it's an important thing for clinicians to know as well. They feel blame, they feel guilt. And so one of the things I say to parents is, I've been a parent for 33 years. And the parent that I was 33 years ago was the best that I could do 33 years ago. Based on where I was in my life, what I was doing, I was trying my best, I was making mistakes. 33 years later, I have more skills, I still do the best I can, I still make mistakes. And I'm always striving to do better. But back 33 years ago, I did what I could, even if now I shudder to think about some of the things that I did back then. Back then it was the best I could do. And so I try to help parents understand that they didn't do what they did out of any kind of malice or poor intent, that they love their kids. And some of these kids are very difficult to parent from the very beginning. You know, they're the difficult temperament kind of kids. And so parents did the best they could, and parents are doing the best they can. And we all just strive to continue to do better, and the same is true of us as clinicians.
Excellent. Excellent. Robin, is there anything coming in from our audience at this point?
Unmuting myself. At this point, no. I see we have some folks here, but you know, I think that the interactive capabilities of the G+, I can't tell if they're watching from G+ or from YouTube, so comment tracker's down. So carry on. You guys are doing great.
Okay. So thank you, Robin. And so, Pat, I want to ask you, what are some of, you talk about intense emotions. Tell me about young people with intense emotions. Who are we really talking about here? Who are we, what characterizes these young people?
What characterizes these young people is that their behaviors, again, for some it's suicidality, suicidal ideation, for some it's self-harm. A lot of kids have self-harm. For some it's substance abuse, for some it's aggressive behaviors, for some it's eating disordered behaviors. For some kids it's anxiety. What what it is about them is that they feel their emotions more intensely. Okay, and the way that we describe emotional intensity or emotion dysregulation is that these are kids that see something happen or that experience something emotionally, and they feel it is so intensely that they go 0 to 100 very quickly. So it's immediate and intense, and it's a reaction to things that other people might just shrug and go, nothing happened. To these kids, they feel whatever happened intensely, and so they go 0 to 100 and stay there. And they have a very, very slow return to baseline. So anybody in their environment sort of looks at them and goes, like, what is happening? What's going on? This is not a big deal. And yet for these kids it is a big deal because physiologically their brain is firing. And so they are vulnerable to this intensity of emotion and to becoming dysregulated by it, and they feel their pain, they feel their anxiety, they feel their sadness, they feel all of their emotions more intensely and more passionately than other people might, because that's the way their brain works. So for some kids, that passion leads them to do great things. For other kids, the pain is so intense that they do anything they can to get rid of it. So the underlying issue is always intense emotions. How it shows itself is in a variety of ways over time. Different kids have different ways of showing those emotions.
So this is, I mean, are these kids the kids that they're born crying and stay crying and everything upsets them from a little
sometimes
gas bubble in their tummy?
Sometimes.
Yeah.
And sometimes it's not. You know, sometimes it's not those kids. Sometimes it's other kids. And for the most part, it is kids that are going to, you know, temperamentally be what we call oversensitive, overreacting kind of kids. I don't like to use labels and I don't like to use judgments. That's why I use quotes. The thing is that some kids, some parents will say, yeah, I've seen that all their lives, and some parents won't have seen it all their lives. For some, the intensity comes with adolescence. For some, it comes developmentally. So it's not always there at birth, although typically a lot of it is there at birth.
Yeah. And I imagine trauma can be...
and trauma is the other piece, yes. So for some kids, this intensity of emotion is there at birth. For others, it develops over time through trauma. Yeah, thanks for that.
In your book, I'll put it up here, Parenting with Family Who Has Intense Emotions. You speak about emotional dysregulation.
Yeah.
Tell me about what is emotional dysregulation? I guess I can guess, but...
Right, that's basically what I just explained. So this intensity of emotion leads to dysregulated emotion, which means that the emotions feel out of control.
I see.
And that kids are trying really hard to find some way to control it, to contain it, to feel a little bit better. And that's what we hear from a lot of the parents describe to me, what they hear from their kids, which is, I just want to feel better. And so the issue is that the emotion dysregulation, when kids are screaming and yelling or throwing things or self-harming, there's a connection between the emotion dysregulation and the behavioral dysregulation, okay, or the challenging behaviors.
Okay.
That's what they're doing in search of trying to feel better and manage the pain that they feel or the intensity of the emotions that they feel.
So the behavior is a response to the emotional reality.
Yes. It's an attempt to regulate their emotions and feel better.
Mm-hmm.
And, you know, if you listen to kids who describe self-harm, they describe how they feel better after they self-harm. If they find it soothing. So one of the things about dialectical behavior therapy is there's a whole set of skills that we teach kids to replace the skills that are unhealthy. So it's all about replacing skillful, healthier, productive behaviors, using those to replace the unsafe and dangerous behaviors that the kids may have learned.
Mm-hmm. Okay. So I'm hearing from Daniel Brown, a PhD candidate in neuropsychology, and Daniel asks, what was that question again? It was up for a second and then it went away. Let's see what it was.
Daniel is curious to hear about applications of DBT for young adults with narcissistic personality disorder.
Okay. Well, since we're not using labeling here
That's
today.
exactly, that was my first question. Is describe what a person with narcissistic personality disorder does, okay? Because it's those behaviors that we're going to talk to, Okay, so if a person with, and I don't know, I would have to hear from Daniel what he really wants to address, but if a person with narcissistic personality disorder is very centered on themselves and not thinking about others, we have a whole module that's called interpersonal effectiveness skills. And one of the things we teach is how do you start to listen to somebody else, how do you validate somebody else. But again, it depends on what's driving those behaviors. What is the emotion that's going on? Because again, I don't look at it, I look at the behaviors as they're remedying something that is discomforting, something that is painful for that particular person. And it's very, very hard for an outside person to understand that this is not just a selfish, manipulative person who has to get their way, that all of those behaviors are trying to meet some need inside that person, and we have to understand what that need is so we can help them find other ways to meet that need. So we don't make any assumptions in DBT about what's driving a behavior. We do very particular and very meticulous chains, it's called chain analysis, to understand what leads to certain behaviors and also what maintains those behaviors. If a person acts a certain way and gets all of their needs met, they're going to continue to act that way because the environment is reinforcing them. So sometimes we really do have to change the environment. If a kid who starts out self-harming because it makes them feel better also learns that they get tons, they can do anything they want when they're self-harming. All they have to say to their parents, I need to go to this party, if not I'm going to self-harm. Their parents start giving them everything they want based on that, they're going to continue the behavior. Same with whatever narcissistic personality disorder looks like, something's maintaining those behaviors. It's working for that person for some reason. So we not only have to look at helping that person learn new skills, we also have to help, which is what I do with parents, help the environment around them respond differently and respond more to healthier behaviors than to the unhealthy, disruptive behaviors.
So Pat, the way we're speaking about this, we're talking about very much about something, a treatment that's very much applied to what's taking place in the present. What are the emotions that are taking place in the present, and how do we approach finding new responses to those emotions in the present. But let's just talk about the person with narcissistic qualities of being very self-centered in a way. Wouldn't another therapeutic model say, oh, but this was adaptive at another time of their life. They developed this particular way of managing emotions at a difficult and earlier time of life. And if we accept that premise, does that get addressed in DBT?
Again, I think it gets addressed largely initially by learning new skills to learn new behaviors. We all know that people can learn new behaviors without necessarily understanding and this is going to come out as a cognitive behavioral person that I am, right?
Sure.
Without necessarily getting at the underlying issues. Now, that's stage 1 DBT. There's also stage 2 and 3 and 4 where we start doing more of the underlying work, sometimes getting at the trauma, sometimes getting more understanding of where it came from. The bottom line, though, is we need to teach people how to regulate their emotions first, so that when they get into more of the in-depth work, they have the skills to manage the emotions that it brings up. Now, the biosocial theory, which is at the core of this, I gave you half of it. And half of it was this kid is born with a very sensitive emotion regulation system. That system is then met with what we call it's a biosocial theory. It is met with what we call an invalidating environment, which is people who, in an attempt to help their kids feel better or out of sheer frustration, say, knock it off, it's not such a big deal, don't worry about it. Okay. Now, I think every parent out there and probably every clinician has at one time or another said to somebody, don't worry about it.
Don't worry about it.
Don't do it to dismiss people. We don't do it to be nasty to people. We do it to help them feel better.
I hear it in the park every day. Parents say, you're fine, you're fine, you're fine.
Right. Okay. Now, that works for a lot of kids. It does. For a lot of kids, it works.
Yeah.
For a kid that has this intensity, they feel like nobody understands me and there must be something desperately wrong with me. And so a couple of things happen. One is the kid doesn't trust their own internal experiences because the world is saying it's not right, okay? Not the way you should be feeling.
Right.
And then they do one or two things. One is they shout louder. And I will tell you from me personally, if I don't feel like I'm being heard, people around me, I tend to shout louder. Everybody around me knows that, okay? And that's what kids do. They shout louder. You don't get it, so I'm going to act in a more aggressive, more self-harming way so that you get it. Or some kids go underground, okay? And they mask their emotions. And they let everybody feel like they are totally confident when inside they are at upheaval, and sometimes that comes and bubbles up. Most times it will eventually bubble up. So yes, there's a combination of what goes on early on, and that's why one of the most important things I teach parents is to validate their kids, to hear them, to understand the underlying pain. That does not mean that parents agree with their kids. It does not mean that parents like it. It does not mean that we do when we validate our clients. It means that we're searching for the piece of what's going on with our clients that's underneath, that they're feeling. I mean, parents say to me, how do I validate a kid who is screaming at me that I'm the worst possible parent in the whole world? I ask parents, well, what's genuine about that? Well, my kid's angry at me. That's what you validate.
That's what you validate.
At that moment, your kid is angry at you, and at that moment, you have probably done something that has made your kid angry. Even if you wouldn't change it or not, you can acknowledge the anger. You can almost say, you know, I'm sorry that it made you angry, and, not but, and, because that's dialectical, right? This is the limit I'm setting, and this is why I'm doing what I'm doing.
So there's a lot more to talk about validation, but I do want to make sure we're getting to our audience's comments and questions, and I think Dr. Burdick had a question. And Robin, can you share that with us?
Yes. He asks, is DBT more effective with meds? And if so, what meds? What is your experience?
My experience?
Yeah.
Okay, my experience is that meds as an adjunct to therapy can be really important. A lot of the kids that I work with, not that I work with, but the parents whose kids I work with are on some kind of meds. And I'm not a psychopharmacologist. What I learned a really long time ago is that actually the meds are treating the way in which this is manifesting itself. So for a kid who's depressed, they'll be on antidepressant meds. For kids that are anxious, they'll be on some medication that manages that. The medication piece is very complex, complicated. You know, finding a psychiatrist that will work with kids and work with parents to find the best mix is a very complicated situation, and I just refer parents to the best psychiatrist they can find, or the best psychopharmacologist, and somebody who listens to their kid. Because again, that validation piece, and you know, I'm going to bring it up again because it's so important for all of us, that if a kid goes into a psychiatrist and says, well, these meds aren't helping, and the psychiatrist says, yes, they are, right, the kid is not going to talk openly to that psychiatrist either. So what we want to do is we want to make sure that the parents are also heard, the kids are heard by who's ever working on medication. But which medication, it changes all the time, and you have to work with somebody who's very well schooled in that.
So here's a question I've got for us, and that is, I think we all understand that if our children have intense emotions, that we need to understand that they're really struggling, and we need to support them in their struggle and support them in learning the skills they're going to need to be able to manage those emotions. I understand that. Adolescence becomes a little more difficult because the challenge of teenagers is moving away from childhood, ergo parental influence. Now it's parents that are trying to help their teens develop emotional regulation skills and to support their teens. At the same time, their teen is rejecting their support because, after all, you're my parent and my job developmentally is to move away from you. But then we get to young adults and it's like, hey, I already raised these kids, you know, you're done. I'm not going to parent you anymore. It's up to you to get this stuff figured out. Isn't life therapy enough? Come on, get on with it. So how
actually, you have, I work, obviously parents come to me as self-select seeing me, and they're seeing me because they really want to continue to help their kids, and their kids are feeling the sense of independence and say, I'm not taking anything that you're giving, okay? You can't talk to my doctor anymore. You can't talk to my therapist anymore. I'm not giving you permission, and by the way, I'm going off my meds because you can't make me take them anymore. So there's both, okay? There's both the parent that says,
pay for my cell phone, and pay for my rent, and if I run out of food, I'm going to come by and pick some up, and oops, I'm going to stay with you for a while because I got kicked out of where I was because nobody liked the way I was behaving.
Mm-hmm. It's really, really tricky. It's very tricky for the adolescent. I mean, what I say to parents of adolescents is that, adolescence is a difficult time anyway. Your kids are having to rebel against you in order to differentiate. And now you have the intensity with which they are going to do that. And young adulthood, which is a time of trying out new behaviors and being independent. Kids with intense emotions are going to do that intensely. And parents sometimes are watching behaviors that are very outside the ways that they thought they raised their kids and outside their moral values. And still, again, the parents that I work with really want to figure out how to help their kids and will do their young adults any way they can, and are scared to death about the kind of independence that their young adult has.
But how do we differentiate between when a parent is actually supporting and helping a young adult who needs continued support and help, and when they're enabling a young adult so that that young adult doesn't really have to learn and apply the new skills required of adulthood? How do you make that differentiation?
I think that in DBT we talk about balancing, giving autonomy, forcing autonomy, which is sort of you're on your own, versus fostering dependency, which is I can't trust you when you're on your own and your judgment is so poor, so I'm going to hold you too close. And what we talk to parents about is balance, is finding that place where you are helping your kid be independent and you're helping them learn how to make independent choices, and at the same time you're available to be helpful. And that's the balance that I try to help parents find. There's a lot of discussion about how much parents should be doing for their kids, and how much they need to say, you got to do some of this on your own. The problem for some of these parents is that their kids are willing to be homeless, to prostitute themselves to get money. Okay? They are actually self-harming, and a lot of parents live in absolute fear that anything they will do will lead their kid to be homeless or to kill themselves.
So they're almost blackmailed from setting any kind of limit, because if they set a limit, then their kid's going to go out and do something selfish.
They're scared to death. Because I talk about that all the time, and actually I tell parents that before I started doing this work as intensely as I do it, I was sort of, get on with your life, and if you can't follow my rules, I was this hardcore parenting person, get out of my house if you can't live by my rules. You're over 18, I don't have to support you anymore. And now I don't say that to parents as much anymore, because I really lay out for parents the pros and cons of keeping things the way they are, and the pros and cons of changing what the parents do to give their kids a push. And I recognize the amount of fear that puts in parents. And so parents have to really wrestle with that. And yes, every parent says, a lot of parents say, am I enabling? And yet I'm desperately afraid that if I'm not there and I don't take care of my kids' bills and I don't give them a cell phone, and if I kick them out, they're going to be on the streets. Really, really dangerous. And it's a very difficult place for parents to be. And so I have to, acknowledge that fear, and also let parents know that they have to take risks and allow their kids to take risks in order for there to be any potential for growth. It's a very hard managing.
Is there a point at which you recommend an out-of-home placement, or a placement with a 24-hour placement for young adults? Does that ever come up in the conversation? Are you familiar?
It comes up in a lot of places. They're very, very, very hard to find, and for the most part, unless a young adult is deemed imminently dangerous to themselves or others, they cannot be placed except voluntarily. And I work with parents all the time who want desperately to place their kids so their kids can become independent and can learn independent living skills, and the kids say, no, I'm not going. Mm-hmm. I'm not doing anything because I don't want to have treatment and I don't want to go away and I want to stay here. And so the young adults over the age of 18, they can't be placed.
So you're saying not against their will. So what you're saying is the challenge is how do you help a young adult who doesn't want help and who, by our observation, given their life choices and their self-destructive behaviors, need help.
And that is a dilemma. And no, that's all I can say, because I think that there just aren't easy answers, and each family that comes, each set of parents that comes to me, I have to deal with the dynamics in the family a little bit differently, and I have to deal with their kids, what's going on. The best scenario is when one of my colleagues is actually working with their kids, and their kids are actually willing to be getting some treatment. Then it works best, because then we coordinate. But I think that a lot of kids, young adults, are not getting treatment, and sometimes they have to wait a while, get a little bit older, until they realize that they want something different. The kids really want something different. They want to make a commitment to change, because the work of change is also really, really hard.
All right. And Robin, have we got something from our viewers?
Yes, we do. There's a comment from Jeffrey Dodd who says, realize it's an emotionally controlling culture. We have a struggle naturally to inhibit emotionality, to channel it towards love and positivity. It's a long quote here. Towards future orientation of a teen who is intensely in the emotional struggle of now. Instead of medication, he says we need more fine attunement to their experiences and their struggles with against our shaping system. We need to look at us and the total context environment.
Yeah, that's a fabulous comment, Jeffrey. I think that's completely in line with what you're saying, Pat. Is that good for you?
I don't know. I mean, I think that I'm trying to sort of think about how that aligns with just understanding and accepting, and I think that there's a dilemma around kids that are unsafe and parents who want to control that and keep their kids safe, and yet we don't want to control everything. We want to allow some self-discovery, and I just think that it's a hard way to balance. It's a hard thing that has to be balanced. Always against, the priority is always going to be safety, and what does that mean in terms of safety? I did work with NAMI, and NAMI really want, some of the parents in NAMI want to be able to control their kids a lot more, and yet there is a lot that has to be said for self-determination and a self-desire to make life better. So what I really think we need is a lot more resources out there that can actually reach kids and understand what the kids or the young adults are experiencing and reach out to them and meet them where they are, not say you have to come to me. I think that people need to go into houses where kids are not moving and where they're stuck, and work on reaching kids so that kids feel understood. So I think that we need tons and tons of more resources, and those resources have to start with understanding where the kid's at and validating that, and understanding the parents' frustration without blaming, without judging, just by being there. And we don't have a lot of that. We don't have a lot of people who are going to be able to have the time to meet kids where they're at, literally and figuratively.
So young adults who are not launching well, that are not hitting their young adulthood with a vision and a plan that they can execute against. That didn't happen on the day they turned 18. That usually happened because their adolescence in some way was not successful. And one of the things that I feel very deeply about is that we are completely underutilizing the resource of adolescents in our culture. They're supposed to go to school, more or less, period. Now, those kids that come from families that provide more can get those kids to engage in the band and join the sports teams and do all the things that will make them feel connected and give them a positive identity and a sense of achievement. But there's a lot of kids out there who are not connecting, haven't connected, and then they hit their young adulthoods and they haven't felt useful in the world. They don't have a sense of themselves as value add.
Well, you have to understand that if there are kids that have intense emotions, and high school, middle school, there's so much going on that's so difficult and painful for kids.
It's overwhelming.
And if you feel those emotions intensely and you go into a social environment that is so overwhelming, you might have a lot of difficulty going. And again, I don't want to blame whose fault that is. I know parents do everything they can to get kids to school, and I also know that school is for some kids, a really painful environment. Mm-hmm. So what are we doing to engage those kids?
Yes.
To engage those anxious kids? Because sometimes it takes somebody at the high school, not their parents, mm-hmm. somebody at the middle school who really understands what a kid is going through and mentors that kid. And I think those are the resources we have to put into helping kids. Mm-hmm. And I think there's not enough of that. Mm-hmm. And band and arts, they're being dismissed from schools. Mm-hmm. When there's how do we get those kids back in? Okay. What are we doing to develop those resources?
Okay. So Pat, there's a book I know that you've written. I want to share it with our listeners today, because you've taken the time to really empathize with and think about the siblings in these families and what they've gone through. And this is called Hey, I'm Here Too, and what it's like to grow up as a family member in a family with a very challenging brother or sister. And I don't want to talk about it too much because we're running out of time. We've got just a couple minutes left here.
Well, I appreciate you saying it, because the kids that I do see are siblings mm-hmm. who have so many mixed feelings about what's going on in their houses with their parents,
yeah.
What's being created, the dangerous situations, the escalation. Mm-hmm. And I wanted to make sure that those siblings feel like somebody hears them, mm-hmm. that they also are important, and give them an opportunity to be able to say to people in their environment, I'm here, I'm not invisible, because they feel invisible. So I appreciate you bringing that up. Mm-hmm. Important of mine.
So Pat, how can people contact you? How can they reach you directly? Where can they find you after finding what a wonderful resource you are? How can they get in touch?
The best way to get in touch with me is probably my website, www.patharveymsw.com. Mm-hmm. That's the best way to find me and find out what I do and find out more information about my books. Mm-hmm. And I respond to every single solitary email that I get. And I hear from people all over the country looking for parent coaching or looking for advice. Mm-hmm. So that's the best way to reach me.
Okay. Thank you. And I would add that people can find me in a very similar way at my website, neildbrown.com. And I've just redesigned my website, so now I'm blogging on a regular basis. So if you want to hear my latest thoughts that are inspired by my latest sessions, please come and join me, and I'd love your feedback as well. Pat, it's been an absolute pleasure. I've learned a lot, and I know our listeners have too. And stay cool.
Thanks. And thanks for the opportunity. I really appreciate it.
Okay. It was a lot of fun.
Thank you.
Right.
Bye.
Bye.